So
you're going to fill that mug of yours. It's nothing to do with the light.
How does this work? Are our faces always on the screen? I don't have Facebook at the moment, so I haven't looked at what it looks like on Facebook.
Yeah, so sorry, I'm just turning this on. So whoever's talking, their face goes through to Facebook.
Oh, okay.
But if you're not talking, you're not showing.
Yeah.
Okay.
But just sometimes there's a bit of a lag, so just be aware of that. So don't finish talking and pour up your bottle of wine.
What was the other thing? Oh, something was on my mind now. I forgot what it was. If it's important, I'll remember it.
No worries.
Oh, showing the. Why did it say?
Shelly, you broke up a bit.
Oh, here we go.
There we go. Yeah.
Did it say practice? Cool. Am I back?
Yeah, I'll try again.
With the did it say practice manager or just registered bio?
Oh no, I can also mention obviously that you're you're head of the practice. Okay, guys, I'm just gonna mute you guys quickly, just so because we're going across. Okay, good evening, everyone. I think we are rolling. Welcome to everyone at home who is watching with us on Facebook. Tonight we have got a very, very cool presentation and live Q&A set. It's all things lower back pain, and I'm very fortunate to have my colleagues with us tonight. So let me introduce myself first. So my name is Shona Hendricks, and I am head of sports science here at SEMLI. For those of you it's first time joining us, SEMLI is the Sports, Exercise, Medicine and Lifestyle Institute at the University of Pretoria. And tonight I'm joined with three very, very esteemed colleagues, and I feel very privileged to work with these people every day. It's quite an honor. So just to start off, I have Professor Christa Janse van Rensburg. Hello, Prof. How are you?
Good evening, Shona. I'm well, thank you.
Good. I also have Darryn Berry, who's one of our sport physiotherapists. Darryn, how are you doing?
Hi, Shona. Fine, thanks. And you?
Good. And and then we welcome back Shelly, who was with us on one of the previous live Q&As. Hi, Shell. Welcome back.
Hi, Shane. Thanks for having me back.
Good stuff. So just a little brief introduction on these three people before we get cracking, because I know them well, and you guys perhaps don't. And if you didn't read the events page, Prof Christa is a sports and exercise physician and rheumatologist, but she's also the head of the section sports medicine department at the University of Pretoria. Prof is currently the president of SASMA, which is the South African Sports Medicine Association. Prof also has a very big passion for running, and for those of you who don't know, was also a Protea netball player. And those are just a little snippets, but has served on many different boards, and was involved in things like the 2010 World Cup here in South Africa as well. So it's been a privilege to work with Prof over the years. Darryn has an MSc in exercise and sport physiotherapy, but he specializes in areas such as rugby, triathlon, and other endurance events. So welcome to Darryn for the first time. And Shelly, but just as a reminder, is our head biokineticist at SEMLI. And well, she's a registered biokineticist, obviously, because she is the head of the department. But her areas of speciality are in orthopaedic wellness and special populations. But Shelly really is our go-to person when it comes to, or go-to biokineticist when it comes to lower back pain. So that's a bit of the introduction for everyone, just so you know. the way we're going to structure tonight, and just get a bit of the housekeeping out of the way, is we're going to talk a little bit about some misconceptions around lower back pain. We're not talking lower back injuries, and just so everyone's aware of that. And then we've got two special cases that we want to take everyone through. So if you guys have questions, if you're watching, drop them into the comments section, and we'll definitely try to get to some of those at the end. But yeah, so just let's just take that forward, and yeah, let's get cracking. Thanks guys for joining. I'm just going to pop this PowerPoint up for us, and we can get started. Just a little bit on perhaps some misconceptions around lower back pain, and starting off, I think one of the ones I hear most commonly is my lower back pain caused from my disc slipping out of place? And Prof, I think this is a great start for you to perhaps take this one, if you don't mind giving us why that isn't necessarily true.
Yes, Shona. So, maybe a slipping disc is a misnomer. So where did it go, kind of thing. So, in our language, we will talk about disc herniation or a bulging disc, and that can imply a few things. And usually if you have a disc that has, herniated or is bulging, you will have referred pain down the leg, what we call a radiculopathy. So you many times get neural involvement, and sometimes the patients won't even have lower back pain. So scientifically, a disc can't slip. And Darryn, I don't know, what do you think about that term?
Yeah, Prof, I think it's obviously we see a lot of sort of patients that come in with low back pain, and obviously when we're listening to what they say and we hear words such as "I've got a slip disc," it immediately kind of puts a little flag up for us that says there's probably a few misbeliefs about what's going on with their pain and their injury. Like you said, to start off with, it's impossible to slip a disc out your back. It requires a lot of force. So the bulging and the bulging disc and the herniated disc is more the common term. But I think the biggest thing that it does is just that sort of psychological thing of to hear that you've got a slip disc is quite a scary thing. And so we're just trying to and break that down straight away to say, well, it's still there. It hasn't run away. And it's just something that we need to give the body time to heal and actually just work on some sort of symptomatic treatment and stuff like that.
Awesome.
Exactly. That's, how we always explain it to the patients as well. And I think it's important for the patients to understand and to actually set them at ease when they get the diagnosis of a disc herniation or a disc bulge, because as you said, the disc is still there. You just sort of need time to recover from that.
Yeah, exactly. The second one, and I hear this often, and I think we all used to push this quite a bit, but is my back pain caused from a weak core? Physio and biokineticist, what are some of your ideas around those?
Yeah, sure. I'll probably kick this one off for us. I think the word core it's come into the spotlight in the last couple of weeks and couple of months actually. It's a very loosely used term, and like I said earlier, is we hear a lot of stories from patients when we're doing our assessments and stuff like that. And so basically when someone says to us that they're struggling with a weak core, again, we say, well, we ask the question, well, what is the understanding of what is your core? And previously it's been known as core is one particular muscle, your transverse abdominis. And I think we've definitely moved away from that thinking. That sort of mindset comes from the 1980s when they first published that sort of research. So, we'd like 25 years down the line, and we've definitely moved on from linking back pain to one sort of muscle that's located in the trunk. And again, it's taking away the blame from one sort of thing and saying, well, there's probably a whole bunch of factors that are causing back pain rather than just one muscle. And to be honest, I don't think we can say what is core. I mean, if you ask anyone, any physio or biokineticist, there's probably a multiple of answers you'll get. And that's the point, is core can't be defined in terms of one thing. It's a multiple factor thing that we have to consider.
Yeah, exactly. I think there's always going to be those almost buzzwords. I mean, TA was it for a while, and then glutes was the next one. Core essentially was one as well. So yeah, there's always going to be those, and it's good that we're here and we have this evidence-based process to it, and then to follow through with these misconceptions. Number 3 is I can't exercise because of my back. I mean, the number of times I've heard that is yeah. I mean, if I had a rand for every time, I wouldn't necessarily be doing this job. But yeah, Shell, what are your thoughts around that one?
Hey, Shanes. Yeah, I don't think I'd have a job if that was necessarily the case. Yeah. So needing to be able to exercise. Well, let's put it this way: if your back's sore, it's not a good enough reason to stop exercising. And there's plenty of research that is out there that's showing that exercise is able to improve your back pain or prevent back pain. So yes, it can be a psychological thing of, okay, if I move, it's going to make my back sore. So the more or the less I move, the better my back will get. But we're actually seeing that rest is really not a good thing to do for your lower back. So yeah. The concept is we want to get moving, and you're going to do progressive overload. You're going to get the right exercises going. So that is also a multifactorial approach. But yes, we don't want to stop moving just because our back is sore.
Prof, do you want to add on to that?
Yes, Shona, so that is very important. And depending on your diagnosis, the exercise may differ, but it is definitely quite important that we keep on moving, because if you stop movement, it will actually get worse. So very important what Shelly just said.
Yeah, I think we, sorry, Darren, 2 weeks ago, we covered a lot of that with the exercise during lockdown, and, everyone's trying to run marathons, but one of the big things is just, just move. Don't be so sedentary. What's that slogan? Almost move, or lack of movements is or sitting's the new smoking. If I've got that correctly. But sorry, Darren, I interrupted you. Anything you want to add on?
No, I just wanted to add on to that. It's exactly that. Is doing nothing is not the best, and doing too much because you've got back pain will also not be a good thing. So yeah, you want to find a sort of a middle ground where you're doing stuff that isn't aggravating anything. But like Shelly mentioned, is you don't want to become fearful of doing something because you've got a bit of pain. And it goes back to sort of that first misconception about a disc slipping out. If you tell someone your disc has slipped out of place, I would also, and I didn't understand medical pathology, I would also be like, okay, I'm probably not going to do anything now, because that's just the misconceptions that we need to sort of break down again.
Yep, spot on. For those of you who are just joining us, I see a couple of people have just joined in. Welcome, and we're running through a couple of misconceptions around lower back pain. And again, just maybe drop a note into the comments there. Let us know you're here. Say hi, and if you have any questions, pop them in there, and we'll definitely try and get to them a little bit later. So, the last one of these misconceptions that we really wanted to touch on is my back out of alignment? Again, I've heard this quite often, and Darren, I'm pretty sure you hear it more than we do.
Yeah, Shona. So it's I think with the amount of information available to us on Google, for example, you can type into Google your symptoms and you'll get a diagnosis, and you can scroll through a whole bunch of pages and find a diagnosis that suits you. And a lot of the time, it's obviously a lot of stuff that isn't really based on much research, and it's really just opinion. So that whole thing of my back being out of alignment, I think. And it's like the disc slipping out of place. To really get a joint that's out of alignment, and Prof will agree with me, you're actually dislocating a joint, and then you can say it's out of alignment, and you would have to realign that sort of with a medical professional, a doctor doing that sort of procedure. So to say back's out of alignment, we'd rather say, well, maybe you're just weak in some areas, maybe you're weak in a certain movement direction, maybe you're stiff in a movement direction, but I wouldn't say that anything's out of alignment. And obviously we use, manipulation of a joint is something physios and other professions use as well. But I think, and there is benefit for that, for manipulation, but in terms of clicking a joint back into alignment is probably not what we're doing. Because like I said earlier, you're probably going to be relocating a dislocated joint if you're realigning it.
Yes, and Shona, many times I think people are, talking about the SI joint. when they say that their back is out of alignment, so they will come and tell me that, they had a leg length discrepancy and they went for a sort of a realignment. It sort of sounds like you're taking your car for a wheel alignment. And it's just not possible. If you look at the anatomy of most of these structures of the spine and the SI joints, there's a lot of soft tissue surrounding those joints. And, for someone to be able to align your back or your SI joints in their rooms, it is impossible. So I think that is quite important.
Yeah, no,
Yeah,
definitely.
just to
Sorry,
add
carry
on to
on,
that
Darryn, yeah.
again, Shona, is so I mean, just using an example of the SI joint, because it's quite a common one that people talk about. And your SI joint has about 5 millimeters of movement, which that is so small and almost insignificant. And obviously, again, there is benefits to doing those sorts of like Prof mentioned, a joint manipulation or whatever. But it's probably just not the reasoning behind it is not to realign something. There's other reasons why it is beneficial, and it's short-lived. It's not a long-term thing. The more long-term solution to something that's out of alignment is definitely exercise. And obviously with the biokineticist and that working on certain things, that will definitely be useful.
Awesome, guys. Yeah, I think so. I think these are 4 things that have come up a couple of times, and hopefully some people have these misconceptions almost thrown out the window a little bit. And if you are watching with us on Facebook, yeah, drop us your thoughts, and we're very keen to hear from our fellow clinicians as well, and some of the experiences that you've had. But guys, to perhaps take it into this first case that we have, it's an acute lower back pain case. And this client or patient presented. She's a 26-year-old female runner. She's an accountant by trade. Sorry, I'm just moving that. The patient is clearly fit. She exercises regularly and she runs some 21 kilometers. And she's recently started some weight training, which she said, I think she had just recently started CrossFit. And she has a 6-month history of right-sided lower back pain of running. But most recently in the last week or so has a recent acute flare-up with pins and needles in the foot at night. And this tended to start the day after, I think, one of her first CrossFit sessions. So Darryn, I think she came forward with you, and maybe if you want to take this case and give us your sort of first initial presentations or assessments that you did, and then we can open it up to the other panelists.
Yeah, sure. Thanks, Shona. I think so. Obviously, I'll dive straight into it. We obviously start with an assessment, and something that we really kind of our stress more than enough is that you need to get a full story, a full history of what is going on. So obviously, we at a first assessment we usually spend 15 to 20 minutes just actually speaking to the person and kind of getting the full picture of what's going on, and do more listening than talking actually, with the goal that there's a lot of information that will form a more accurate clinical picture than just a quick 5-minute chat of what's going on and let's just do a quick fix. And I mean, if we're using this case as an example, the thing is that the patient's got a 1-week history of pain from doing CrossFit. So immediately we'd say, okay, there's definitely probably some form of pathology going on in the back, which would be causing that. But then if you just give more insight into the fact that there's been pain for 6 months, we need to consider that there's a bigger picture. And just that initial assessment for us is, sitting down and listening and talking and actually doing a bit of counseling at that stage as well to work on more than just the pathology. And I think even going back further than that, leading up to when pain started 6 months ago, there's probably a bigger picture of before that as well. So, I mean, at the end of the day, we're talking about a biopsychosocial model, and obviously the biological part of it is that possibly a herniated disc or a facet joint or something that's injured. But then the psychosocial factors are what we try and listen for in an assessment. And, when I hear someone say they've got 6 months of low back pain, you're really starting to think of, okay, well, there's more probably like psychological stuff that's happening. That is either as a result of pain or that may be contributing to ongoing pain. And that goes back to what we started with, sort of the beliefs about back pain. I mean, if you tell someone now you've got a slip disc, they probably, like I said earlier, it's probably a scary thing to hear because of the stigma around it. And they will hold on to that, probably believing, oh, I've got a slip disc, I can't do much for 6 months, and eventually you're going to start getting symptoms of chronic pain. So that's a psychological thing. And then just the third aspect of it, the social part is, you know, if someone wants to run, is a 21K runner, and they haven't been able to run 21Ks for 6 months because they're in pain, you know, socially that's going to do something to you. Obviously, I think it's a bit different for elite athletes, but for your recreational weekend warrior, a 21K race in the weekend is an important thing. And if you can't do that, you know, we have to treat that as well, because we're not treating a disc that's injured or facet joints that's injured. We're treating a person, and that person has social issues, that person has psychological issues. So in our assessments, I'll go back to it quickly, is that we're looking for the full picture. And then if I just go back to the case, you know, someone that has neurological symptoms, that sort of radicular pain, pins and needles at night, that's a little red flag that we say, okay, this is probably a bit more of a serious issue that we need to consider. And then we ask, okay, how accurate do we need a diagnosis? And whenever there's sort of radicular nerve pain, we say, well, there could be a serious pathology going on, especially with the pins and needles sort of issue. There's a nerve that's sort of irritated somewhere, and then we would want to get like imaging or more further professional opinion. So, you know, we'd give the suggestion and offer the service of a doctor specialist for diagnosis to the patient. So I don't know if Prof wants to jump in here and quickly just talk about how she would, if we had to refer this patient to her with a 1 week history of radicular pain, how she would go about assessing it, and sort of just with the imaging and what we can look for in that.
Sure, thank you, Darren. Yes, so I fully agree that you need to do a complete history and a clinical examination, and the history will include a few things, because you're sitting with someone with a 6-month history. So it's not just an overnight thing, and now suddenly she flared up. So I would like to know a few things from her history. You know, what kind of management did she have before? Did she have an actual diagnosis, for example? And regarding the pins and needles, is it only at nighttime? You know, is it aggravated by walking up or down steps, for example? And also, you mentioned that it's now going to the foot, but many times patients will tell you, no, you know, it's only down to my knee. So all of that will give you a little hint of where you should be looking at. And whenever I deal with back pain, especially if I think it's mechanical back pain, I sort of want to work with structures. So I want to look if it is disc, if it is vertebra, or is it perhaps the facet joints. And depending on what movement aggravates or make it better, it will sort of direct me into what way to go in. And then, of course, with the examination, you always get, you know, a story from that to actually guide you on what your possible differential diagnosis will be. So many times after the clinical assessment, we're still sitting with 3 or 4 possibilities. And in this case, you know, it may be that the patient has a facet joint problem, so the joints to the back of the spine, where you can have impingement on the nerve roots. It can be that, you know, that slip discs that we talked about is still a possibility. If it's right-sided and it's more in the glutes, I need to think SI joint, for example. So a few things that you need to exclude, and also very important for me in my history and examination will be to look at it in a systemic way. So I want to know a few things extra. I want to know about possible skin involvement, other organ involvement, because this may also be something more than just a mechanical problem. If I take it that this is most probably a mechanical problem, my first port of call will be a normal x-ray of the spine, because I can see quite a bit on the x-ray. Many times patients just jump to MRIs, and sometimes you really just need a x-ray. For example, if we're dealing with a young kid with a sore back, they're doing gymnastics, and I think it's a stress-related injury and it's been for a few months, on x-rays, I will be able to see quite a few things. So we definitely need MRI in some cases, but it's not always needed. Also on the special investigation side, ultrasound or sonar won't help you quite a lot with lower back problems. X-ray will help. A CT scan will help because that can show you pure bony involvement. And then the nicety of the MRI is it's like an anatomy atlas to us. You can sort of see all the structures. So if you're really not seeing anything from the X-ray, you're suspecting that there is a nerve root or a disc herniation, then the MRI will really show you quite a bit. And many times people do not quite get it. If they tell you, for example, they have leg pain, you tell them it may be their back, they sort of go like, I don't have lower back pain. And then, if you show them that, this is how it works with the dermatomes and the myotomes, and they sort of get the picture, because that's also part of the management, to educate our patients. So that is a lot that I've offered, Darryn. I hope I've answered your question.
Yeah, no, that's perfect. I just want to ask another thing back to you is, obviously we're living in an age where financially it's not always possible for patients to actually go for imaging, especially an MRI. So obviously an X-ray is a bit cheaper of the images. If I can just ask you if you would like to send a patient for imaging and they actually can't really, they don't have the funds for it, how serious of a setback is it in terms of management, like especially for if you feel that it warrants, is it an issue, or can we actually kind of carry on without the image?
So unless you have red flags that you've already mentioned, then you can wait, and before you need to now dish out 8,000 or more to do that MRI scan. So many times we can start with management, and we know with back pain, especially if it's mechanical and you don't have a serious nerve root impingement or radiculopathy, that most of them will actually get better with conservative management. So you can definitely wait with some of the special investigations.
Okay. Yeah, thanks. That helps. I think because there's just a lot of patients that we see, we always give them the option. We say, would you like us to refer you up and for imaging and for a better opinion? And a lot of the time is the financial issue is spoken about, because, imaging is an expensive thing, especially if you go, but, like you said, in some cases it is definitely warranted, but if not, we can kind of get away with it as well, with just going without it. So I mean, just carrying on in terms of just going back to this case that we're looking at. So obviously the patient is symptomatic. So we're going to start treating sort of symptoms, and I'm not going to go into details about that. I mean, that will become a physio lecture. But the point is someone with neural pain, we want to get the pain. We want to obviously start getting that sort of night pain away first. We want to see that disappear. There's possibly sort of stiff muscles, stiff joints that we can loosen up, immobilize, and work on that. But I think, and once that, hopefully within 2 or 3 weeks, that is really settled down quite a bit. And at that stage, patients, let's give it 4 weeks. Patient might feel, there's actually a complete improvement, and not really keen to carry on. But then we start looking at the 6-month history of back pain, and that's more where we go, what came first, the chicken or the egg? Or essentially, if someone's got pain for 6 months, that could have been the cause of an acute flare-up from doing a weighted movement in CrossFit, for example. So then we would want to start working on the things that we find that may cause a pain from 6 months ago. And that's when we start looking at your biomechanical assessments and seeing what's going on with the patient. And I mean, just this patient in particular, what we found was that there was almost no lumbar extension movement when we did the assessment. And something, obviously, if you're doing running, you need good range of motion in pretty much all your joints that you're using for running, especially in the back and the lower limbs. So if you're missing sort of a movement in the lumbar spine, you're gonna compensate somewhere. Or missing a movement somewhere else, you're going to compensate in the lumbar spine, for example, and overload that area. So what we found with this lady is that so lumbar spine extension was an issue, but we dug a bit deeper and we found that actually her hip extension kind of movement was almost non-existent, to say. And so that's something that we started working. Obviously got the range in the lumbar spine, but started working on the biomechanics that went there in terms of exercises. And I don't know if Shelly wants to jump in here and just start talking a little bit about the progressive rehab and stuff like that. Obviously, from physio side, we start with the rehab with sort of your groundwork, your base work, getting muscles activated, getting sort of that neuromotor control going. But then at a later stage, we need to start integrating that sort of groundwork into more functional movements. And then also with progressive resistance plan to get, that hip extension movement going, because obviously if you're running without hip extension, you're looking more at overloading another area. Hip extension is quite an important movement that we need for running. So Shelly, I don't know if you want to jump in here a little bit about sort of just planning a progressive rehab plan for working on, movements and stuff like that, if you can add any comments there.
Thanks, Darryn. Yeah, no, with that, especially if we've already gotten a bit of a diagnosis and a referral from the physio, that helps us a lot. So we don't just jump in, we'd also normally do a bit of an assessment ourselves. And when we're looking at the lower back pain, it's obviously a multifactorial condition, and we're not going to look at one thing specifically. So like we mentioned right in the beginning, we're not going to just look at a person's core, person's glutes. So what we normally do is then look at a functional movement assessment and see what muscles they're recruiting, what activation sequence they're going. And then we start basic, if the physio has already started basic, with getting the activation going and getting the groundwork. So we really want to get a good ground. I like to put the picture of a house. You need a good solid foundation before you're going to build that house. And if that foundation is set with good activation sequences, good knowledge of your body, good understanding of the body, then we can start building on that. And then we look at the functional movement and seeing, are they recruiting the actual muscles that we want them to recruit. So if they're going to do a squat or going to do a lunge or do stepping up, stepping down, we're going to check and see for compensation, check to see if there is a good stability in the muscles that need to be stable and good mobility in the muscles that need to be mobile. So it's difficult to say specifically, obviously, as I haven't worked with this particular case, but you want to start basic, you want to start with simple movements, but then try and move into the movement. So she's a runner, want to get into simulating movements of running to make sure that she's recruiting the right muscles in order to avoid her from, or to stop her from probably protecting certain areas or avoiding and moving in certain motions because she's scared it's going to cause pain, and then therefore protecting those areas. So that's kind of how our take is. It's starting simple, getting more functional, getting more dynamic with movements, and ending hopefully getting these individuals stronger than what they were before the symptoms of the back pain started, with this case 6 months prior. We want to get them to a better position than they were then.
Yeah, no, thanks for that. I think the one thing that you mentioned, I think it's a progressive periodized plan is probably like hugely important. If you've got the groundwork laid and you have to progress from where you were 2 weeks ago, and obviously then we have to start looking at patient goals as well. And you sit down and you say, well, the goal is for example here to run a 21K. And I think also actually she started doing CrossFit. So the goal would be to actually do CrossFit without getting continuous back pain, without getting injuries. So that's essentially where we really look at a functional movement screen and say, well, like how does the person do a squat? How do they do a deadlift? How do they do all that stuff? And then, implement that progressive plan, like Shelly was talking about, actually loading on resistance over time. And obviously, I think, one can't expect that in the space of 4 weeks, there's going to be a massive turnaround. I think a progressive loading plan doesn't, it takes time. And the sports scientists also know probably more about that than us, that, fitness doesn't occur over a short period of time. You need to work on that continuously. And it's the same with building. We're using the word resilience now in the physio world quite a lot. But basically building resilience for this lady, for example, to handle doing CrossFit loading. And CrossFit is obviously, it's a repetitive movement under weight. So it is a heavy load. But we just need the body to be resilient, to be able to handle the loads that she wants to do with CrossFit. And then, I think just on a side note, taking away from this case and just moving on to sort of an older population, going again, there's a great video that I saw a couple of weeks ago about a really aged lady. She must have been close to 80. And she was in the gym, busy doing deadlifts, busy doing squats with weights and stuff. And it's not something you see every day. And I think the point that they were trying to show with that video is that the body is resilient. And at the age of around 80, if you've been doing something long enough, you can be lifting weights. And that whole thing of once you start aging, don't lift heavy and don't do this and don't do that. I think we need to move away from that and saying, well, just progressively build up your resilience to whatever you need to do. So this lady doing 21K runs and CrossFit, I think, when we chatted to, obviously she went to a CrossFit for a couple of weeks, and they put her under a bar with weights, and she wasn't used to squatting with weights. She was used to doing sort of body weight movements. And for me, that was where the injury came, that the body wasn't able to handle what load was on top of her back when she was squatting and deadlifting. And again, it's something we broke down and said, listen, you'll be able to do it. You just need to build it up a little bit more slowly than what you were doing.
Yeah, I think that's exactly it, Darryn. And I'm here as the Q&A host, but as the sports scientist, you've hit the nail on the head, and progression is key. And weight training or strength training isn't, again, there's a misconception. We can have a whole Q&A around that, just on, perhaps even from young children all the way up to older adults, and how ensuring that the training is done well, and the technique is correct, and that the progression is there. That is more of the focus. And yeah, you've hit the nail on the head with that exactly. But Prof, I know you also wanted to add something along those lines as well, or perhaps to another point of Darryn's earlier.
Regarding this, I think perhaps a misconception that we left out is about use of medication. And many times patients think that if they take an anti-inflammatory or a painkiller, that will resolve the problem, and they're not really looking for the cause. Like Darryn now said, this was, a problem with not being able to extend her back, and they could get that right with exercises, because most people want quick fixes. We don't have time to do some exercises, and also many times, as soon as you feel better, you stop with those exercises, and that's when we see them flaring up. So I do think medication has a role to play, but it, in this case, will be symptomatic treatment. So it's really to help the physio and the biokineticist on their way with the rehab program. That will not be the cure for a patient with a problem like this.
And I think I also wanted to add, Darryn also had a good point, trying to work to the patient's goals. What I've seen with the few professions is they have certain go-to exercises that they like to use for certain conditions, but a patient has a certain goals and likes and dislikes. So I think creating the patient's autonomy, making them feel like they've also got a little bit of a say in what's happening, and enjoyment out of the treatment program. So getting them back to what they wanted to do, like if they wanted to get back to CrossFit or cross running, not to have that impression of, no, you've got lower back pain, you're not going to be able to do that anymore. So yeah, I think it's really important to work towards those type of goals for the patient, and making them feel like they've got some sort of control over what's going on. Sometimes that lack of control also has a bit of a psychological effect on individuals, and that just flares up the condition even more. So getting a person just feel like educating them, I think, like we've mentioned right in the beginning, is just such an important part with these type of conditions, and getting them to feel a little bit of control, and allowing them some control over what's going on.
Cool. Yeah, you're right. Prof,
yeah, Shelly, just to add to that again is, so I mean, if I just want to change the case to that older lady again, for example, if you've got a older lady that struggles to get out of bed, her goal is going to be very different to this young lady who wants to CrossFit. And essentially, when we're talking about exercise as medicine, with especially like in the aging population, a simple sit to stand out of a chair is essentially a squat. And you can progress that basically from doing a sit to stand from a very high chair, sit to stand to a very low chair. And then you can, if you're with a biokineticist in the gym, you can add weights onto that and start actually getting progressive overload like that. It's a really simple thing, but I think we just forget that if you break it down to its core principles, movement can be progressed into pretty much anything. And I don't know, Shelly, if you want to comment on anything on that.
I'm going to, I think these are great, but we have an hour, and I know we have quite a bit to cover. Prof, you had one more point you wanted to mention there, or are you happy to?
I think maybe, also something to mention, Shona, will be surgery. People, as soon as they have back pain, they sort of afraid that you will now send them for surgery. And I think we need to get the message over that it's really a few people that really need surgery if they're suffering from lower back pain. And, you know, I always explain to my patients, you sort of deserve surgery. You don't just ask for surgery. And there are a few things that we will look out for clinically that will tell us this patient can't now just carry on with the exercises that, you know, Darryn or Shelly have prescribed to them. And just some of those symptoms will be if you have chronic night pain, you know, unbearable pain, if you have pins and needles that sort of really with you all the time, if you have bladder problems, you can't control urine, if you're not feeling when you're wiping yourself, you know, when you're urinating, those will be the things that tell us you can't go without surgery. So in some cases, we need to send patients for surgery, but those are the minimum. And I think it is important for people to know that.
Yeah, 100%. Thank you, Prof. I see there are a couple of questions coming through on the Facebook page. Guys, just hang on. We were going to run through the second case, and we definitely are going to jump into some of those because luckily enough for us, some people have brought up one or two more misconceptions around lower back pain, and I think it's going to be good to answer a couple of those. So, but we want to jump into this next case, which is a bit more of a chronic case. And you can see, so it's a 41-year-old male, has had a progressive increase in lower back pain over the past few months. And he's been diagnosed with a kindalizing spondylitis and is at the age of 35. And as a result of this, obviously, has decreased activity over his activity levels over the years. And he is no longer physically active and really nervous to start any exercises in the event as it causes this flare up in the pain. And he's also recently had a change in profession and is involved a lot more in IT at his current company. So yeah, I'm gonna open that up to the panel to dive right in.
All right, I'll go in. So usually with the chronic lower back pains, these are things that the bios tend to see more often. And we often get a referral because a friend heard that you go see a biokineticist, or they've been referred not necessarily through the proper chain. So usually when someone walks into the practice and they're complaining of high pain thresholds, lower back pain, referring pain, these are good times to sort of ask right initially a good question. And Darryn said, you know, spending 20 minutes having a good history taking and conversation with the patient. I would say that's on case, like minimum time. I've often had a person, if you let them go, they can chat to you for an hour. So, but it's important because you develop a relationship with those people in that time. And I think that's a really important thing, to have a good relationship with those patients. But having said that, these are the things, I would suggest that if there's high pain ratings, that the buyer should be referring them for proper diagnosis, and then for probably getting the physio involved quite quickly into the pain management session. And it's a good opportunity with a patient like this to work together with the professionals, and not necessarily feel like first you see the doctor, then you see the physio, then you see the buyer, but it's a good opportunity to work as a team. So Prof, I don't know if you want to touch on what ankylosing spondylitis is, give people a little bit more of it's big words that not everyone will have an idea of.
Thank you, Shelly. So ankylosing spondylitis is one of the diseases that we will call inflammatory back pain. You will recall that earlier I said mechanical back pain, and the opposite of that will then be inflammatory back pain. So the patient will tell you that they've had chronic back pain. It has a gradual onset. It's usually people younger than 45 years old, and they will complain of pain and stiffness more in the morning, while with mechanical back pain, it's usually during the day when they do certain movements. And typically people with what we call angst-spon will feel better if they move. So you want those people to do exercises, and they will tell you that, you know, in the night they have pain because they're actually lying still. Angst-spon is just one of the possible diseases that you can get with inflammatory back pain, and that now goes back to the bit I've said on the first case, where you now need to know if there's skin involvement or other organ involvement for possible things like psoriatic arthritis, reactive arthritis. All of that can come into play. But I think what's important in this patient is that he may have double pathology. So he has been diagnosed with angspon, implying that he's possibly HLA-B27 positive. It's a gene that they carry in 90% of these cases. But he also tells you that he has been sitting for a long time. His work is IT, so most probably he's sitting behind his computer. We've all been in lockdown, doing a bit of exercises, and then we sort of revert to working on the computer. Some have time to watch television or do some gaming.
Prof, I'm sorry, I'm interrupting you. I know that's rude, but can I just say I'm quite chuffed that even though we're in lockdown, that's the first time we've spoken about lockdown tonight. It's been so refreshing to actually have a conversation that hasn't been revolved around lockdown. So apologies for interrupting you, but
sorry that I now brought it up.
No, I think it's great. I think it's excellent, but it's been quite nice to not have to have that. So I apologize for interrupting you. But
no, sure. So in this person's case, we will need to perhaps think that there is another problem as well. It's not necessarily the angspon playing up. There can be a mechanical problem, so he will need a proper assessment, like Darryn alluded to in the first case.
Prof, can I just quickly throw a question at you, just for clarity? Angspon is a lifelong problem?
Yes, absolutely. So the HLA-B27 gene we find in a few people, and I think also a misconception is that when people know that they have the gene, they think they have the disease. That's also not true. So the gene can go what we call dormant. It's only if the gene is active that you will actually have disease. You will have pain and you will have stiffness. So you will carry the gene for the rest of your life, but you may not have active disease always. And typically what we see in patients with angspon, they have a clinical picture that sort of, it comes and goes. And that's also many times why patients will stop medication, because they start to feel better, then they stop their medicine. It's not like with the other diseases, rheumatoid and that, where you get, the disease just progresses over time. Angspon comes and goes, and so the patients many times, unfortunately, play around with medication. But I think the important message is that you carry the gene for your life, but you don't need to have the disease for the whole life.
Yeah, I think that also just goes back into the fact that with the fact that exercise needs to be maintained as a sort of chronic medication in a sense. Exercise is medicine, essentially.
Absolutely, and these are the patients where we allow hyperextension exercises, because remember what ankylosing spondylitis implies is that you will stiffen up in a flexed position. So we want patients to go into extension. We don't want them to sit at the desk with a flexed spine. If we advise them to do cycling, probably mountain biking better than road cycling. So those are the kinds of things that we need to tell these patients that get stiff inflection.
Also, if we're going to talk about modalities, and I don't know, Prof, if you agree or not, but I find that getting the right sort of modality of exercise is really important. So obviously, what the patient wants to do and is likes to do and has been doing is important, and getting them back to what they were doing, not getting them afraid of that. But I know modalities such as hydrotherapy works really well, and I've had really good results with things like hydrotherapy. Is that something that you like to refer your patients towards? Just your opinions on different modalities of exercise.
Absolutely. So hydrotherapy works quite well for any inflammatory joint disease because you're taking the impact off the joints. And I think the nice thing about this disease is that you really want the patient to exercise, as Darryn said. So a few things that, you know, is probably not good will be contact sports. So that is tough if you have a young guy coming with back pain, thinking it's because of the scrummaging, and in the meantime it's this disease, then, you know, contact sport perhaps not the best. Running is also a bit of impact, but I will allow my patients to do it with enough recovery time, and enough recovery time in my mind is 48 to 72 hours. So if they like running and you take it away from them, they're anyway going to do it. So you also need to speak to the patient. So I will tell them, okay, let's do the running, perhaps not 21 Ks, get a nice 10K every now and again, do it every third day. But in between, you do cross training, you do hydrotherapy, which is very important to get the joints through the range of motion.
Awesome, thanks, Prof. And yeah, I think that holistic approach is really, really important. And Darryn, you're welcome to step in, but like when a person's presenting with a lot of pain, I like to talk about a pain rating scale of 0 to 10, with 0, no pain. Usually I say 10 is excruciating, you want to jump off a building. And I like to work anything below 4, you know, that's sort of the pain ratings. I'm like, okay, I can still work with these people. But if it's 5 and above, I generally like to refer to physiotherapy. And I was just wondering, what are the sort of modalities you find could work well for these individuals?
Yeah, so I think obviously with pain, anyone that's in pain is definitely where the physio needs to step in and start working on that, because it's going to limit essentially what you can do in terms of exercising. So, you know, it's a tricky one with managing where is the patient at in terms of what they need. So, yeah, pain levels is definitely a good way to go about it. And essentially from my side, what we'd want to do is obviously reduce pain. It's pretty simple. Get them moving freely through full range of motion as much as they can get. And as soon as, and that's why I asked earlier, is angst more a lifelong sort of issue? And that's where we'd say, okay, you know, you're not going to stay with physio for 20 years. You know, you need to be exercising structured by yourself, but also in a structured environment. And that's where sort of we'd say, okay, we got your pain under control, we got your movement under control. Let's give you over to the bio again so that you can kind of carry on where they left off before you got referred to physio. And then progress from there. And then obviously, like Prof said, there will be maybe flare-ups at some stages. And at that stage, you know, it's okay, well, let's go back to physio, kind of work on symptoms again. And then it's a back and forth thing. And that's just where sort of the success of a multidisciplinary team in this sort of example is really just based on monitoring the patient of where they are at each stage. And obviously for longevity, we need to know that exercise is going to be carried on for a very long time. And that's just sort of where the biokineticist involved is, you know, you guys are really good at giving long-term plans and encouraging patients to actually stick with those long-term plans. So, you know, if I assess a patient and, you know, they have angst and I'll say, well, listen, we're going to treat your symptoms, but I think let's hand you over to the bio for long-term management, because, you know, there's probably more benefit from this patient being with a biokineticist for long-term than a physio.
Yeah, perfect. And that's also where, like, it's really important to just look at your basic guidelines for exercise. So even with a person with back pain, you don't it doesn't necessarily change what your body needs. And what the ACSM guidelines basically are is that you need to be training at least 5 days of 30 minutes moderate intensity. And that's important for lower back pain as well. So get to that body moving. Stretching, you know, that's got its pros and its cons, but it's generally what I find it helps to relax. And people who are in pain are generally quite tense, and just getting a good stretch after a good warm-up, and it can be as simple as a walk or going for a shower. Stretching can have that psychological benefit as well as the physical benefits as well. So that's really important. And then just getting that fit principle, frequency, intensity, time, and type, I think is really important with the bio, trying to balance it out. And there's no cookbook approach. We don't have a set rule of things that are going to work for every single person. So it's really important to know that when a person comes and presents to you, you're going to have to do that individualized program, looking at the assessment, going through the results of your assessment, and then planning according. And it has happened where a patient, I thought certain exercise X, Y, and Z would go well. They start off well, and then as we progress, we don't exactly get the progress we want. And that's when you need to take a step back, relook at the picture, ask other professionals for advice as well, and then try a different approach. So being able to change your approach as well is really important. We've got our basics. We know, yes, core strength, I know we spoke about in the beginning, is not the cause, but there is research to say that it can be beneficial in your exercise programs. But no, it's not just that TRA or transverse abdominis. It's a multiple, like we've mentioned, Darryn, you and I have chatted in the past with the lumbar pelvic girdle. So looking at that whole lower body, the movement patterns. So just taking an approach of looking at an individual, seeing their movement patterns, watching what they're doing, and then developing a program for them, and then progressive, systematic progress, and getting those people to back to movements that they do through their daily living, not sticking to basic, simple exercises, but actually getting that progress through your programs are really important.
Good stuff. Prof, you want to jump in there? Go ahead.
Yes, Shona, what I find works well with patients, is if they like the exercise that you tell them to do. If you now tell them you need to do hydrotherapy, but they're not going to go to the pool, you failed already. So you need to sort of adapt whatever program you think they need to what they will do. And then also, secondly, to give them a goal, for them to work towards something. Usually helps. So, tell them about the park run, and the first time you're doing only a 1K, and then you sort of try and do the full 5K, whatever goal you want to set out. But I just find that works with the patients if we can do that. And I can't agree more with the multidisciplinary team that Darryn and Shelly have spoken about, because, every one of us has a role to play, but we don't know it all. So we're all there to support each other to the best of the patient's outcome.
No, exactly. And I think, it's something that we at SEMNI are so proud of is that multidisciplinary approach. And we're very fortunate in the environment that we have with that. But that's not to say that can't happen in other practices outside. And I think that's the approach that lacks quite often. Guys, last sort of points in this case. I do want to move to questions. Is there anything really pertinent that someone wants to add on this case specifically? The
only thing of sitting down for long periods of time, it's just researchers showed that even if you're physically active and you do your 30 minutes and it's right in the beginning of the day, or you do 10-minute bouts to make up your 30 minutes, if you're still going to sit for 4 hours nonstop, that can be a slight problem as well. So constantly getting up, and I know it can be distracting. You think you're down and you're in the zone, and to pull yourself out of your work, it can be distracting. But at the same time, just getting a bit of a walkabout, a quick movement, it can actually just enhance your concentration, and it's just beneficial just to get up and out of your chair. So that was the other point I'd like to bring in with that.
Yeah, I think that's spot on. So I've read so many articles around working, and here I go mentioning lockdown, but working around lockdown time, but exactly that. It's so different to what we used to, but actually urging people to move a lot more for the purposes, obviously, like you mentioned, but also just to refresh their minds and so on. So, okay, guys, that's awesome. I think I'm gonna take a few questions, because I know some people are desperately wanting some answers. And if we don't get to your questions tonight, I'll ask the different professionals or clinicians to jump on and see what we can answer. Let me just say, from an ethical point of view, obviously, we're not going to provide any kind of advice directly to people on this forum. We'd really want to rather do proper assessments and so on. So if there is something specific, we really do urge you to get in touch with any of the clinicians at SEMNI. But there's one question here, and I think it brings into a bit of a misconception. We didn't really touch on it, but it's around imaging. And it says, what is the correlation between imaging and pain? There's very different ideas on this. And Prof, maybe if I can bring that one to you. You mentioned a lot about imaging and x-rays and MRIs, but is there a direct correlation between a really bad result on an image versus the amount of pain that someone has?
So Shona, the short answer is, on a scale from 1 to 10, it will be -5. So the imaging is not giving you the answer. It depends on the symptoms, and then if you can relate that to the imaging you do. If I send 10 people for an MRI scan, 8 out of those 10 will have pathology, and they will not necessarily complain about back pain. So there's not a good correlation between those, no.
Okay. There's a question here from Daniel Sneeman. He says, I have sudden spikes of pain in my lower back when bending forwards at a certain angle. What could it be? again, we're not trying to diagnose anything here, but Prof or Darryn, I guess, are you, either of you perhaps want to just give an indication, and we can always dive further in.
Sean, I think it's one of those classic things. You're standing around a braai and a friend says to you, "Don't you want to just check my back out for me quickly?" It's honestly, it's not possible. Like we said, there's multiple reasons why you might have pain. So obviously during this time, obviously the physios we are available at our practice. We are open. So whoever that asks that question, I'd recommend that they go and see a physio. Even if it isn't us, but go and see a physio that they can help you with a diagnosis.
Awesome. Yeah. Sorry, Prof, carry on.
Yeah. Just, also reminded the people on what I said about, movement, flexion and extension. So, definitely, as Darryn said, you can't make a specific diagnosis, but if you're bending forward, thinking about the structures that will get stressed, it will be your vertebra, it will be your disc. And in younger kids it can be the growth plate. So if you have pain on bending backwards, you now think about the facet joints, so the joints to the back of the spine, and then also what we call the pars interarticularis. So that is sort of the communication between the vertebra and the facet joints. So you can sort of give a vague diagnosis, but I agree with Darryn, you can't do a specific diagnosis.
Good. There's one or two others, and I think just in the interest of time, I just want to get to this last one, and then almost just ask each of you to give your last parting shot on lower back pain specifically. But if someone has lower back pain, where do they start to get it sorted? Should they go see a doctor? Should they see a physio? Should they go straight to a bio? I mean, obviously don't ignore it. They need to go see someone. I'm open. Everyone, I'd like to open this to the floor completely, but where would be the best place to start?
Yeah, Sean, I'll start. Sorry, Prof. I'll start with this one just to say, obviously, I think generally, as physios, we tend to be the first line of call for the population. I think it's just generally, but obviously being a first line practitioner, we are allowed to make diagnoses. We are trained to make diagnoses. So if you are in pain and you're having an issue with doing whatever it is you do, if you're a sportsman or work in an office. If you have pain and you have limited function, I'd suggest you either start with a physio who then can refer you to a doctor or a bio, whatever's necessary, or you start with a doctor, because obviously that is probably the highest port of call. I think it depends sort of what is the severity of your issue. If you really are almost paralytic and you can't walk, you'd probably want to start with a doctor, because that would be, the higher order of severity. But if you just generally have an ache or pain, you could definitely start with a physio, and we can kind of refer you where you need to go.
Darryn is implying we're the bearers of bad news.
Sure. I don't know about that, Prof. I think, I mean, we've been working together for a long time. You always bring me very good news every time I've come to you for consultations. But Prof, your input on that, I mean, I'd love to hear your side on where you think patients should start.
Yeah, I agree with Darryn, that depending on the symptoms and the reason that you have back pain, that patient will sort of choose where to go. And unfortunately, as we know, sports physicians are not well known to the public. So many of them will go to the physios or the biokineticists first. And I don't say it's wrong, but what I would like to ask my colleagues will be that, if you feel that your patient is not making progress as they should with the diagnosis you have in mind, please refer sooner rather than later, so that we can sort the patient out.
Yeah, I don't work very much in the clinical sort of side, but whenever I've worked with an athlete and particularly with runners, if we're struggling, it's very often because there isn't a diagnosis, and you don't get over that. And I think exactly that. So to the colleagues out there who are listening, and definitely to us where we work, it's very important to have that diagnosis to then know your treatment plan and your course of action from there. So
just sorry, last thing on that. I think at the end of the day is the goal is to get the patient better, and whatever's going to be best for that, we need to consider and allow that to happen, basically.
Yeah, exactly. Patient-centered is the goal completely.
Yeah.
So maybe just a last parting shot from each of my colleagues on lower back pain, something you would want the world to know and about lower back pain, where just your last sort of conclusion or parting shot. Shell, let me start with you, because we haven't lost you. So you're still with us. So do you want to give us your last parting shot from a biokineticist's point of view?
Oh, well, my last point is really, and I think everyone's going to jump on board here with my group here, is just that exercise is medicine. So especially with the word biokinetics, we're life through movement. So we're going to encourage exercise as much as we possibly can. So my parting words is, if you're struggling with your lower back pain, if a movement hurts, avoid doing that movement. But it doesn't necessarily mean that your best and favorite activities are down the window. We just need to look at you individually and try and set up goals and set up a structured program to get you where you want to be, provided it doesn't irritate or flare your pain.
Awesome. Let's jump on the other order. Darryn, your parting conclusion?
Yeah, I think obviously also movement is best, so exercise is medicine, but I'll also just say that the back is resilient, the body is resilient, and because you're in pain and whatever you believe about your injury or pain it's not always 100% correct, and your body is resilient to a whole bunch of things that you throw at it. So yeah, that's what I'll have to say there.
Good stuff. And Prof, from you?
And from my side, I think we need to know that 80 to 90% of us will have back pain at some time in our life. So it is very common. It's mostly not serious, and it is very important for us to keep on moving, like both Shelly and Darryn said. Sometimes it's more serious. You may need a proper diagnosis with medication, but mostly it's not serious, and we can continue with conservative management.
Awesome. Well, thank you so much. I just want to say thank you to my colleagues for their time on this Wednesday evening, even though we're still in lockdown. I mean, it has been lifted somewhat, but yeah, really, really informative and good value information here. So thank you so much for your time. I hope everyone watching live on Facebook enjoyed. And if we didn't get to your question, I will definitely ask some of the clinicians to jump in and see where we can help you. But if there are specific things, please do contact us at SAMLI. You can contact just the general email for now, info@samli.co.za, and we'll direct you to the correct physician or clinician from there. But yeah, thank you very much for your time. Be sure to join in again next week for the live Q&A. We're really enjoying giving these, and stay safe, exercise safe at this point in time. Even though we got freedom between 6 and 9, it's important to look after your immunity and don't rush out there and run crazy marathons. Well, if you can run a marathon between 6 and 9, then that's impressive, because then you're running 3 hours. But yeah, stay safe, and thank you for your time, colleagues, and all the best. Have a good evening.
Thank you.
Okay, I think, Prof.